So welcome to King's Health Partners Haematology Primary Care Podcast, or better known as the KHP HaemPearls series. My name is Rachna Chowla, and today's podcast we will be focusing on a favourite topic of primary care, B12, and the common queries that me and my colleagues have around this topic. I'm delighted to be joined by Dr Deepti Radia, who is a consultant haematologist at Guy's and St Thomas's, which is part of King's Health Partners. So thank you for joining me and Deepti today, and I will go ahead with our first question. So Deepti, can we start off by having a little bit of a reminder of the importance of B12 in the body, please?
Thanks, Rachna. As you know, that this is a challenging topic in many ways, but a really important one and a very common question that comes up, and we see patients with this issue. So B12 is really needed to form the red cells and the DNA. It's really the DNA component that's really important. It's a key player in the formation and development of brain and nerve cells, so within the myelin sheaths, which explains why if you have severe B12 deficiency, you move down to getting the neurological damage. So that's really the key thing. The other thing to bear in mind in terms of physiology is that B12 binds to protein. So there's dietary sources of B12, and there's a range of them, not all dairy, which we'll go through, but it binds to protein within the food products. It gets transferred to the stomach where the hydrochloric acid and enzymes free it from the protein it's bound to in the food, attaches itself to intrinsic factor, which then takes it down into the small intestine where it's absorbed a little bit more in order to be utilized for that important job of DNA synthesis and red cells. So it's kind of the pathway that I bear in mind when I'm thinking about where could the problems be with B12 deficiency. So hopefully that gives a bit of a background.
Yeah, that's so useful. And you mentioned the word intrinsic factor in the stomach, and I guess we'll talk about that later because, of course, those two things can affect B12 absorption.
Absolutely. And so intrinsic factor is needed to transfer that B12, as we said, across. And then intrinsic factor, if we're looking at one of the causes of B12, just to feed it into here, we're talking about pernicious anemia, and that comes up regularly, is a specific antibody for pernicious anemia. We tend to also do gastric parietal antibodies, and that's not particularly specific because you can get gastric parietal antibodies with lots of reasons. So when we're investigating for pernicious anemia, actually one of the things that holds true is that people have a family history of significant autoimmune disease, autoimmune symptoms and signs, and a family history of pernicious anemia, they're more likely to develop it. So, treating them, maybe you have a lower threshold than you would do otherwise. And in terms of the antibodies, you do both intrinsic factor and gastric parietal, but bear in mind, intrinsic factor antibodies are more specific. If they're positive, you're definitely there.
Okay, so that's one reason for a B12 deficiency. What are the other things that we need to think about in terms of B12 deficiency?
So again, think of the pathways. So again, first of all, what's wrong with the stomach? You've got the B12. Dietary is most important and will be the most common because if you've got inadequate intake, you're not going to get the food in order for it to then have the B12. Then secondarily, what's going on in the stomach? So anything that affects the stomach in any disorder. So achlorhydria, as you get older, more elderly patients develop B12 because they've got atrophic gastritis. PPIs very commonly affect it. So PPIs will cause a low B12 because they reduce the acid in the stomach and therefore change the absorption of it. There are other medications we'll talk about later. Anything these days, we do a lot of bariatric surgery. So anything that's called surgical intervention to change the size of the stomach or the lining can cause a B12 deficiency. And then move further down the gut. As we said, some of it is absorbed from having been taken down with intrinsic factor. So anything with the small intestine, so inflammatory bowel disease, celiac disease. Again, any surgery that's affecting the gut or malabsorption can also be a cause of B12 deficiency.
That's so helpful. So we've talked about deficiencies and we've talked about some of the screens that we would do. So you mentioned antibodies and the celiac screen. What's the role of some of the other blood tests that we should be doing, like reticulocytes? When should I do that? Or
so I guess taking a step back a little bit, the classical picture of B12 deficiency, isn't it? It's supposed to be the macrocytic anemia.
Yeah.
And that happens very rarely. The classical feature of somebody presenting you with these lovely symptoms that you think, they've got B12, and then you have a big MCV and you find the hypersegmented neutrophils and the ovalocytes. That is lovely, but it happens very rarely. Also bear in mind that 25% of patients that present with some sort of neuropathy have a normal full blood count and a normal MCV. So it comes back to that clinical history is vital in terms of these non-specific symptoms. The other challenge we have is B12, just the B12 assay, the cobalamin assay, is very variable and not particularly sensitive, which is why there's no definitive markers, which is why we have this intermediate range. So suspicious of B12.
Right.
If
Okay.
you know it's high and that's great. But you can't specifically say if B12 is low. So you have an intermediate range and then you have a definite low. High B12 is not really a medical problem, doesn't cause a neuropathy. We're worried about the low B12. So we move on to the secondary, more specific assays that are now carried out, like the methylmalonic acid or the HOLO-TC. And those are a bit more specific, and they will tell you that there's a functional deficiency. So you'll find in most laboratories, if they get the intermediate bit, the clinical history fits, then they'll move on. And in our lab, we go on to do the methylmalonic acid, the MMA. And what happens is that if you have a B12 deficiency, within that pathway, the MMA rises. So with a low B12, you should get a raised MMA that tells you there's tissue deficiency to act on. So those
Okay.
are kind of the combination of B12 ones.
Okay. Do they get done? Does that get done automatically?
So in our lab at KHP, it does. Doesn't happen
Okay.
in all places. So that tends to be the default going on through. And some labs will offer HOLO-TC, which is also a similar assay to do, just to see if you've got functional deficiency.
Okay. If I can ask about drugs, you mentioned PPIs just now. I didn't realise until recently that metformin can affect
So
B12.
metformin can cause a reduced B12, unless it's very low, doesn't cause a functional problem. Omeprazole, as we said, PPIs, the oral contraceptive pill can also cause a low B12. So it's bearing in mind. So then when you put patients on these drugs and they're also getting older, then check the B12 level and the MMA. Just be certain, because you've got the silent B12 deficiency. You don't want to present later on with the paresthesias, which are typical because they're too late down the line. So if someone is complaining of non-specific, or not complaining sounds terrible, if they're presenting with non-specific symptoms and it hits that this might be the cause, exclude dietary and do the assays, specifically the more sensitive ones, before you start treatment.
Okay. And if I can ask, maybe is there ever a place for using an intramuscular injection, and then if someone doesn't like that, changing it to oral? Or
so for the ones that present with very low and neurological disorders, as you know, as per the BNF, load them up straight away, because that can be irreversible and that's an emergency. And then we tend to put patients on 3 monthly IM injections, because actually that's helped with compliance in elderly patients, and people forget. And some patients might need them a bit more frequently than 3 monthly. I'm sure you've come across that. People get the fatigue. 2 months is fine. It's negotiating with that patient. In Sweden, there have been studies showing that oral B12, that's high dose oral B12 of 500 micrograms, or 1,000, which is much higher than we do, actually works, because it goes to that smaller intrinsic pathway system at the bottom of the small intestine. So I've put patients on high dose, but ensuring compliance and taking a regular vitamin, and knowing that actually it's a medication, not just a vitamin that's helping them, so that you can move patients over on those grounds.
Thank you so much.
Perfect. I think we've kind of got to our 5 minutes, and there's always lots more to talk about B12. So we can always pick this up and do a further podcast and some more information if there are more questions that are needed. But I think we may have to wrap up this one. And with that, I'd like to thank you all for joining us today and listening to both Rachna and myself. I hope you've learned something along the way. There always is something new to learn. Please spread the word to your colleagues about sharing the link, and we really would appreciate it if you would complete the poll at the end of this podcast to let us know what you think. If you have any unanswered questions on this particular topic, let us know. We'll pick them up at a future podcast. If there are any other topics you'd like to let us talk to us about, please let us know, and we'll be very happy to do that. Thank you very much.